So, unfortunately, I'm going to interrupt your lunch, but do keep eating, because I quite like the irony of a nutrition talk while we all have lunch. Love it. So, does anyone mind if I crack on? Yeah? Is that all right? So, you've seen most of the evidence, so I'm literally going to rock it through just as a reminder. There's been no assessment of nutritional status of homeless people. I think in the UK, I can't find anything in the UK, and it's certainly the only thing that I can find published was something way back in 1999. It's profoundly fundamental. You know all this. So we did a large cross-sectional survey in London, sampling people who are being screened alongside the van. It was peer-led, and you may have noticed that Bora's not here. Bora's been in bed with a busted back for 3 days, which is a disaster because Bora really led this. Bora was the front end. Bora did 99% of the interviews. Bora made it happen. Bora works for our service, has worked for our service for nearly 4 years now. She comes from an expert by experience background, and she is dynamite. So she's gutted she can't be here, so apologies on behalf of Bora, but I will say this is down to her incredible enthusiasm. Peer-led research, I think, gets a better response, full stop, to anything that requires honesty and disclosure. And so one of the reasons why I think this session's been not repeated, but it's different, this session's on now, is because we really want to get you engaged. We really want to work together to try and actually do something about this. From a measurement perspective, having somebody with lived experience who knows the score at the front end of this in terms of actually running the survey tool, that really worked. It was guided because there was a need for some robust structure in it. But everything, as I say, all the measurement, everything was done by Bora. We opted for a 24-hour recall food diary. Most nutritional surveys use food frequency questionnaires, but I mean the idea of asking somebody to go back over a week was a bit nonsensical. So we went for a 24-hour recall diary. That worked really well. And I'm going to share with you a few smatterings from some of the semi-structured interviews we've done. So there's some quite rich qualitative research going alongside this. And we've split the groups into rough sleepers, hostel residents, one specifically for women and one for staff. So in terms of trying to create a tool that gave us some serious validity, as it were, in terms of external comparator measures, and obviously a tool that was up for the job as far as measuring malnutrition, I would really advise to amalgamate the following. When you take the Malnutrition Universal Screening Tool, the Drug Abuse Screening Tool, and the Fast Alcohol Screening Tool, and you take away all the duplication associated with these tools, you can actually condense it into something that's really quite short and sweet and doable. MUST, which many of you will be familiar with, is available on the BAPN website. There's some really good training associated with it, but it's dead easy. It's designed for adults. It's an initial assessment and a monitoring tool, and as I say, it's really straightforward. And it's been used across the UK and internationally for many, many years. It's a robust tool. Capturing data on recent drug use was really important. We veered off the map slightly in terms of the traditional DAS. We wanted to actually get a handle on which substances people are using, because there's obviously a huge impact in terms of people on crack and heroin, spice, etc. And FAST, which you'll all be familiar with, dead easy. But again, to be able to control for drug and alcohol use, etc., was really important. So the variables, basic demographics, duration of homelessness was in there as well. That's obviously, it's a very good example of homelessness being a dose-related response. One mistake I think we made in terms of, I mentioned yesterday, our adjusted BMI does not account for people with ascites, people in fluid retention, etc. There's a lot of people who have got, kilos, useless kilos, in inverted commas, that they're carrying around for a variety of reasons, mainly associated with liver disease. So I would probably recommend adding MUAC to the tool as well, because that really starts to capture the muscle wasting. Another mistake, in inverted commas, that we made initially, but we corrected for, we initially went for a questionnaire that tried to capture fasting for an entire day. So did you not eat for 1 or more days in the last week? That was a mistake, because multiple people are not eating for 2, 3 or more days consecutively, which came out in the qualitative work. But again, now we've revised the tool, which we'd love to share with you. That's a really important thing to capture, particularly when we start thinking about refeeding syndrome. And we also captured food sources, where people are getting their food from, alongside the 24-hour recall food diary. You've seen all this before, so I won't go through it. You can all read. And here we are, this massive left shift in terms of BMI, in a completely different population when you look at a matched external cohort. Just a reminder, the cohort came from Health Survey for England, where we matched people on a ratio of 1 to 20, age, sex, matched them, and we amalgamated 3 different years of the most recent years of Health Survey for England data, so we got a pretty robust comparator group. 17.2 with a BMI less than 18.5 versus 1.3 of the general population. That's a 14-fold risk ratio, as I say, not accounting for ascites. But again, the MUST tool really importantly captures unplanned weight loss. So if you've lost 10% or more of your body weight in the last 3 to 6 months, unplanned, that's a serious issue. And what really pushes the score up from sort of 17.2 with a low BMI up to 1 in 4 being at risk of malnutrition is that recent unexplained weight loss. I quite like slopes and cliffs. There's quite a clear gradient in terms of low BMI and socioeconomic status as we move from IMD 1 to 5. I've never seen that done. Everyone talks about the relationship between obesity and IMD, etc. So I had a look at that too, and it's really not there. That's quite interesting, isn't it? Yeah. I mean, the cliff in terms of the homeless sample group on the end is quite clear, but obesity is pretty rock steady across the indices of deprivation. Fruit and veg, 1 or more portions per day, again pretty flat but lamentable in our sample. And then just to prove the adage, there's always one. Yep, there was one person who managed to eat 5 portions of fruit and veg in the day before, but as I say, that's nowhere near a recommended balanced diet. And back to this issue of starving, long periods without eating, and that was so profoundly linked to addiction. There was an incredibly powerful and clear relationship. So I'm just recapping on the data so we can hopefully open up to in a bit more of a conversation. So it's really common, it's really severe, it's completely unmeasured in an anthropomorphic sense, and it's really unrecognized, I think. But when you think about the differential morbidity and mortality outcomes, it must be playing a serious part in driving those risks. Nutrition is so fundamental. So back to our challenge today, there's very few modifiable risk factors that we can actually identify that are completely on the causal pathway that we can do something about. But diet is something we can do something about. It's so fundamentally there. So the risk is also modifiable. So for the rest of this short session, I'd really like feedback, I'd like conversation about the whole issues around access, choice, education. The wrong foods is a huge issue, and then this starvation issue, which just challenges me. Just throw a few quotes here. This is a male rough sleeper. Street homelessness means you skip meals, and food is the last thing on your mind. You end up foraging in bins. The access to food is intermittent, it's poor, and it's very much on other people's terms. In terms of choice, this guy says to us, homeless people don't have an option. You go to the day centre and eat what you're given to survive. And education, this was really common feedback. We need advice on healthier ways of eating. Knowledge is power. Key workers should help us, point us in the right direction. I have not a clue what I need to eat to have a healthy diet. And 83% of this sample group of nearly 300 people were really keen, were really up for the idea of trying to improve their diet, and education was a real component of that. I'm just going to touch a little bit on the harm min. This is a spice user. We had quotes from people using crack and heroin, etc. But I'm underweight, I'm on spice, I don't eat for 2 days, I just take drugs. And in this sort of chart, in terms of, you can see on your right how often do you skip a meal. It's split between people who do not use drugs and people who reported drug use. 80% of people who are reporting drug use are skipping at least 1 meal a day, and 60% are not eating for a day or more. And as I say, our stress, that's often consecutive days. So we're looking at 2 or 3 days of starvation. So 60% had a starvation period every week. And in blue, I mean, the thing that, this shocked me. Why should both the BMI status and reported periods of starvation be identical between a sample of people who we are working with on the street, who are no fixed abode, and a sample of people who are in hostels? Conversation.
I mean, when I first worked in a hostel 20 years ago, people would pay 3 meals a day if they had to pay a service charge. It was never easy, but then when supported people came in, there was the idea that people needed to be empowered to cook for themselves, so that it went into kind of a self-catering model. And I think that's where things, I don't think it was perfect. Like, I tell you lots of horror stories about the cook in the hostel and some of the food produced. But I think, it was seen as too paternalistic at
Right.
the time to feed people in hostels. And so, it was a cost-cutting exercise, I think, to actually, enable people to cook their own meals. But what didn't happen with that, I guess, is, and I think there was lots of effort, for people to be alongside, it takes a lot more effort then.
Totally.
To get people to actually
Do it.
Yeah.
And I think that's an alarming insight, isn't it? If there's no measurable difference between the appalling nutritional status of people on the street compared to people in hostels, there's something wrong. If you're under the care of a hostel provider, I think the race to the bottom has seen food fall off the map. That's something we can really do. Again, welcome bigger conversations about this. I mean, the mood thing kind of really gets me. There's, this whole kind of notion of recovery, the recovery agenda in terms of people who are struggling with addiction. If you're bang on it in terms of crack, heroin, or alcohol, etc., your response to every need is more crack, heroin, and alcohol. And poor diet is so linked to your state of mind, your mood, and I think the notion of somebody with someone who's cachectic, who hasn't eaten for or certainly hasn't eaten anything substantial, perhaps for days and days on end, being given no real option to engage in a harming agenda that's got food at the heart of it. I mean, that to me is nuts. There's no evidence for this in terms of no one's really picked it up. I can't really find hardly anything in the literature. But I think there's got to be a really plausible relationship between risk of overdose and being incredibly underweight and coming off a period of starvation. I suspect that is one of the real drivers of death, premature death in terms of amongst the substance use. And we've seen the highest number, as I reiterate, of drug-related deaths reported in this country since we began measuring it. And the department told us it's all due to the aging cohort effect. Well, that's codswallop. We looked at it through a lens of soft tissue and vascular infections in hospital episode statistics data. It's across the age band. We've got 3 years' worth of data on the age band 15 to 34 years old. They're going up too. That's not statistically significant yet, But with the 2 more years' worth of data, if it carries on in that trajectory, it will be statistically significant. And there we have a window to say we've got a younger cohort of injectors coming onto the market. This is a huge issue. There's no one really sensibly thinking about trying to integrate any kind of nutrition intervention into substance misuse services. From the point of view of soft tissue and vascular infections, you know, I mean, malnutrition is the most prevalent cause of immunodeficiency deficiency on the planet. It profoundly delays wound healing. I won't show you that. You're having your lunch. Go back to it later. But you know, I'm basically going to go, you know, back in the day. You know, I mean, I remember when people who were collecting their script, etc., and going to needle exchange services, you know, you would, you know, try and get some calories down their neck. It wasn't that mad, and it wasn't that long ago. But this is where we live today. You know, this is our reality today. We're not having a conversation about benzos today, but you know, the no Ensures issue is really alive and kicking. It's something that, you know, I've seen signs up for in multiple general practices. And, you know, there's a lot of misinformation and kind of, you know, people don't really have an evidence base to inform the no Ensures sign, other than the fact that, you know, people say, you know, if you start with someone who's got substance misuse issues, it's impossible to stop, you know, it's not a replacement for food, you know, it's not actually addressing the root problem, and they're only going to sell them or give them to their mates, you know, but if their mates have got a BMI of 17.5, then that's fine by me. So there's a lot of confusion. This is pretty much the, you know, you can find loads of these, but GPs should not prescribe oral nutritional supplements in substance misuse. Substance misuse is not an advisory council for borderline substances. It's an interesting name for an organisation. Indication for prescribing nutritional supplements. Scottish are a little bit more pragmatic than us, some more recent guidance. Obviously, the food first approach is important. They want people to be referred to dietitians, but they're still referring back to the ACBS guidance. You need specific indications. Those specific indications are about, you know, malabsorption, you know, some bypass surgeries, you know, end-of-life care. There's a range of very specific medical issues that you need to, you know, tick a box on before we should apparently be extending the idea of using these oral nutrition supplements to you. And the current guidance as it stands is basically you need to hit all these criteria. It gets more punitive because they're saying, you know, well, if you miss 2 appointments, then you should stop, you know, if you're blah, blah, blah. So you've got to have a BMI of less than 18.5. You've got to have evidence of recent significant weight loss. That would be from the MUST tool, greater than 10% in 3 to 6 months. You've got to meet the ACBS criteria above, which, as I say, are a very specified list of medical conditions. Dietary advice has been often followed for 4 weeks, so you've had someone who's regularly engaged with you, and they've basically switched onto, you know, a kind of hand massage, kale-based sort of approach to life. The patient is in a rehab program. They're collecting their methadone or an alcohol program, or they're on a waiting list for one. So you've got to tick every single one of these boxes, have another serious medical condition, and you know, you've got to be on time, you've got to be, you know, you've got to be able to get to your appointments, and, you know, you've got to doff your cap. Thoughts? This is current guidance, yeah? Is that acceptable? Alex?
I support, a lot of people I support, but also a lot of my mates as well. They bump up against it all the time, and I've got a mate who goes away with his husband, and I'm really moving that really inspiring. The thing is, because he's in Lambeth and we don't get something in Lambeth, there's no way I can actually get that support. And I kind of went to his doctor, and the thing is, I'm wearing international and stuff like that. I said, well, look, can we maybe explore malabsorption? And the doctor told me, oh, yeah, well, you're obviously not practically, and therefore that's why you're losing weight. And
Barriers.
I mean, I've seen people actually when here they've got into like thinking out there and they're struggling with like I think they were heroin addicts. Then they've had to come off the heroin and go on to methadone. Now that is a step backwards. Like I mean, you know, cut from heroin and methadone. Thank you for the heroin one. It's a lot easier. In fact, a lot of people who've got methadone habits switch on to heroin to come off it. But the thing is, jumping through these hoops is a serious problem, issue for the trying to get in.
So you've nailed it. I mean, the idea of you being on the programme before we're going to address your nutritional issues is completely the wrong way around. Surely having a really poor diet, being very underweight, is so linked to mood, etc. It must be one of the factors that's actually driving chaos and addiction. And the idea of waiting until people are willing to engage with scripting, etc., to then grant them access to nutritional support, that's completely nuts. It's the wrong way around. Totally. Possibly dietary related.
I was just going to say, anecdotally, probably from my own experience, when I managed the outreach service, a young woman came to me and she said, you need to get me into hospital, I need to see a psychiatrist, I'm going mad, I can't calm me down, and then said, what have you been, she'd been speeding, up speeding,
Days.
Yeah. She hadn't slept, I cut her a deal, I thought she was bed and breakfast, we went and bought a big carry bag full of, good food, and said to her, Monday morning, if you're still feeling the same, I'll take you up to hospital myself. And of course, Monday morning she felt fine, she slept, she'd eaten, and I just think we underestimate.
Eating and sleeping. Yeah.
We underestimate the power of sleeping and eating and how that is good for our mental health. I mean, we know it all when we look at all these nice apps around, maintaining good emotional health and well-being. It stays as applies, doesn't it?
You've got a microphone. No. So we're kind of stuck in even NICE have adopted this as their standard in the most recent guidance. So this is where we're stuck. And I think we're in the wrong place. So, I mean, just to sort of structure the end of this conversation, and we've got a bit of evidence. It's not enough evidence. We need a bit more evidence. We've got a bit of an opportunity for some advocacy. If you can't advocate for food, what can you advocate for? It should be reasonably easy to advocate for food, yeah? And so in terms of action, this should be a reasonably quick win for us. This is something we can really do something about. Most people are reasonably keen to attach themselves to ideas that are quite plausible. And that mind-blowing science that you just threw at us then, where the evidence would suggest that eating is actually quite good for you. We should be able to do something about that. But I really do think collectively, and as the faculty, we're going to have to challenge this guidance. I think it's wrong. I think, and just not least the idea that you're not even eligible for consideration until you're willing to be scripted. Point at the back.
It was just a comment, really. There's the new, it's not so new, I think it was the last year or previous year, collaboration called NutriTank.
Okay.
Which is a collaboration between nutritionists, dietitians, GPs, medical students, mainly looking at GI health and the relationship between neurodiversity and that sort of thing, and also impact of toxins from the gut to the brain. That's where it originated, I think, but they're doing lots of work together and trying to get this sort of teaching on nutrition into the medical graduate and curriculum, but also to look at nutrition in a greater sense. So I wonder whether it's something that they might be interested in looking at or taking up, or we flag it to them.
Are you volunteering?
Yeah,
Excellent.
do that. Why not?
Do please get them involved. I think, back to this issue of right food, I came across this cookbook that this wonderful dietitian in Dublin was using. And it was a cookbook that had been put together for people people on chemo, people in sort of palliative care. And it was wonderful. It was like the opposite of a healthy eating book. It was like the most incredible amount of calories and really yummy stuff packed into small portions. And I just thought, this is exactly where we need to be going in terms of trying to support people, people in hostels, in inverted commas, where, for whatever reason, some people haven't got a massive appetite. And, the kind of approach to multiple small snacks throughout the day might be a bit more acceptable than sitting down for your 3 square meals. And so I think we can have a proper conversation and get some expert dietary advice in terms of, let's provide some cookbooks, let's provide some actual, hard, tangible, evidence-based, informed advice in terms of what food should be provided. Because what we've seen through the survey is people are living on mountains of empty, thank you, Pret carbs, and very little else. There's profound shortage of protein, a micronutrient in the diet, and it's currently the wrong food, yeah? It's fundamentally the wrong food. And if you're a day centre, there's nothing malicious going on here. I think it's an oversight. If you're a day centre and your mission in life is to feed people, who are, a lot of them coming in from a night out in the cold, I think the sector would welcome that. I think they'd really welcome that. And I don't think we'd be offending anybody if we said, we could improve this, and there's a real need to actually pack different foods into the diet. Hiya.
I just wondered if I could follow that up about wrong food. I did a study on the experience of homelessness for teenage mothers.
You've got a microphone. Thank you.
I was just wanting to follow up what you were saying about wrong food and also food provision in hostels. I did a study on the experience of homelessness for teenage mothers. So by definition, these young women were under 18. So they were 15 years old, 16 years old, 17 years old with a baby. In Great Britain, 21st century. Oh, there we go. And when I was doing the research, it was quite common to... I was visiting young women in hostel accommodation, and quite often you'd see a very young baby who might just be starting to wean. That's sort of, that age where they start to sit up, about 8 months old, very young, being given just a whole bar of chocolate as their meal. And one of the issues was this issue of food in the hostel, allegedly to promote individual choice and autonomy, or was it to cut costs? They had to fend for themselves. And most of these young women had no knowledge of what was good. They didn't have the means to cook healthy food. And it was not only affecting them at the beginning of their lives, but their babies.
Absolutely. No, the consequences are catastrophic.
Catastrophic.
I think we need, we've got a bit of St. Mungos in the room, we've got a bit of Salvation Army in the room. I think we need the bigger providers to stand up, get together and say, we're going to do something about this. We're genuinely going to do something about this. It's a question.
I think the general approach of the NHS for nutrition is very poor, not even in this population. I'm a GP in Manchester, and then it's only recently, if you think about the headlines a couple of years ago, people in hospitals were starving, people in hospitals were being assessed by dietitians. Ill people who're spending months on wards were not being assessed by dietitians. So I think I think people would be really interested in this, but I think the starting point of the NHS is very low. It's only recently that Manchester seems to have started investing in dietitians for the general population. Patients are getting more consistent sort of plans coming out of hospital for their nutrition, and patients in the community groups like palliative care, older people, and that's only just recently in the last 12 months. So I think the start, and
I think dietitians would be very interested in this area. I think they have increasing sort of roles in the NHS, and people are increasingly willing to fund them because they understand the connection between nutrition and health. It just needs extending to this population. So how many dietitians have come to this conference, say? It's not something that's on a dietitian's radar, this area of healthcare, is it? It's like everything. We're getting psychologists to work in hostels now and day centres. We need dietitians to be working in these arenas and kind of assessing. I'm a GP, I have fairly limited skills, so I make a fairly rudimentary judgment when patients come see me about their BMI and stuff like that. And that's not just my homeless patients, that's also my other patients that live in the community. But I've started referring my other patients to the dietitians because they get a better response. Right. But still, it's very difficult to refer a homeless patient for the usual reasons. But, I mean, we could have a dietitian working in our service, for a day a week, assessing these patients, giving them very clear plans, giving them nutritional supplements. It's not rocket science. No.
Absolutely, but they are like hen's teeth. They're very, very difficult to find a dietitian. And the idea, we've evolved services that are really accessible to our client group. We take services to people, and yet the guidance is still talking about, you've got to be able to attend your appointments. Your 2 strikes and you're out approach to life. They're not on the same page. We understand some of the challenges of access and engagement with services. It sounds to me, from what I've read, that perhaps people don't really understand some of the challenges of trying to use our system when you're on the street. So I think I'm under some pressure to wrap up, but I'd like to propose, please get in touch, because I'd like to think about putting together the following sort of groups. And please express what you're interested in. I'd like some people, if you've got specific expertise and interest in nutrition, brilliant, get on board, but you don't need to have, because it strikes me as it's a bit of a no-brainer. I'd like to look very specifically at the issue of food provision in hostels. I think we should, and I think that should be led by some of the big national providers, and I think we can make a real fanfare about that in terms of involving people who can donate freely of their time and energy, who are not in the sector. I'd like to look specifically at the more kind of extreme end of the market. I've lived off British Army rations for weeks on end and didn't do me any harm. The bottom line is, I would be dead if I had opened the box and it would have just been bread. The reality is we need to get some proper expertise in terms of what we should be providing on the street, what we should be providing in the day centres. We need to pack some serious calories into that. The whole harm-min agenda, you can't really rationally think about a harm minimisation agenda with someone who's got a BMI of 16.5, is having 48, 72-hour periods of starvation on a weekly basis, and is probably at quite serious risk of some metabolic catastrophe if they were to have a huge load of food after a long period of starvation. We've got to get nutrition back onto the harm minimisation agenda. It's got to be fundamental. And part of doing that and part of changing the guidance, I think, would be a specific approach using this evidence to NICE, probably, to say that we think the current guidance is wrong. We think it's completely inverted and upside down, and not least the anathema of having to be scripted before you're eligible to engage with a nutritional intervention. Obviously willing to take any other suggestions, and I think we've got a couple of minutes for questions, but over to you.
Had 3 perhaps comments. The first one, you were talking about evidence, and maybe we don't have evidence in overdose of low BMI, but we certainly have evidence in withdrawal from alcohol that your risk of Wernicke's is seriously increased if your BMI is low. The second is, are we the only CCG where even if you got through the guidelines about prescribing ONS, you have to provide powdered products, which of course are only useful if you've got access to milk, and you can afford to buy it. And the third one was, substance misuse services, not Ensure anymore, but there are some, nice pret sandwiches or croissants available from FareShare, which obviously they're getting. So
Stale sandwich,
yeah.
full on. Aye.
I worked in South Sudan in emergency response for 3 years, and one of the big responses that we would undertake is big emergency crises due to high rates of malnutrition. And we would set up treatment centres and go in with the public health interventions, with water systems, etc. But after sort of years of not noticing that we were making any sustainable impact, we looked, and there was much more research that was done. And actually what the recognition was because of years of war, people had lost their family units and their community units, and that information of how to look after your family and feed your family had been lost, had been lost over the years. And actually just thinking about this and thinking about our population, when we think about the rates of neglect and about, you know, the care leavers rates, etc., that information has never been there for this population. And so it's just thinking about it in the broader context of the community environment, the linking in with the different projects, how to provide that information that has never been there in the first place.
Absolutely. I mean, I have an Italian colleague who I discussed this with, and, you know, back to that kind of nonsense about, you know, this is very paternalistic, us providing food for people, you know, let's empower them by not giving them anything to eat. And this Italian guy was just absolutely blown away by the idea that, you know, how could we not just value the idea of trying to sort of eat together, you know, the idea of eating together. I mean, yeah, it's you know, the whole word companion, yeah, comes from the Latin, you know, with bread, compan. Companionship is about eating together. You know, there's no shame in eating together. I think we could do, you know, when you think about some of the wonderful evidence around, you know, how to design space better, how to use, you know, lighting better, how to you know, co-design things together. And I think with food at the core, you could start to do something pretty impressive, even in a hostile environment. Done. Thank you very much.